We'll start off with the pretest questions. Crohn's related isolated long segment structure of the afferent limb related to the ileal pouch is best managed with A. Dilatation, B. Biologics, C. Surgery. Go ahead and vote. Next question. Septic complications after an ileoanal pouch may mimic Crohn's disease? Yes or no? This is the case. We have a 41-year-old male patient who initially had a diagnosis of ulcerative colitis in 1985. He underwent a 2-stage proctocolectomy and pouch 13 years later. He had good control with good function of the pouch and excellent quality of life. 5 years later, he developed perianal fistula, which healed spontaneously. We do not have a lot of information pertaining to that. For the last 2 years, he had been developing recurrent obstructive symptoms with abdominal bloating, sense of incomplete evacuation after bowel movement. What's the most likely diagnosis? Is it likely to be Crohn's, adhesions, or pouch dysfunction? For the sake of time, I'll keep going with the presentation rather than stop. We'll have some panel involvement and audience involvement later on. The patient at this stage had a CT enterography, which was normal, and went on to have a pouchoscopy. The pouch configuration was a J. The neo-terminal ileum had active inflammation. On a scale of 0 to 6, the inflammatory level was a 2. The pouch inlet, there was a stricture. It was ulcerated, 2 cm long, moderate severity. Tip of the J was normal. The pouch itself, on a scale of 0 to 6, the inflammation level was 1. The cough and ATZ, there was some loss of vascular pattern on a scale of 0 to 6. Active inflammation was 2. Biopsies were taken. Who do you think performed the pouchoscopy? Was it Dr. Ramsey, myself, or Dr. Shen? Any guesses?
Well, the 0 to 6 is Shen's.
Oh.
I guess everyone knows. There's no post-test on this.
No, you're getting undue credit, Dr. King.
Well, I don't know. Maybe people think I'm a gastroenterologist. So the patient underwent balloon dilatation of the stricture. And as you can see from the pathology here, there was some focal inflammation of the ileal mucosa. There was no evidence of granulomas, pyloric gland metaplasia, or dysplasia. Similarly, nothing classically suggestive of Crohn's on the other biopsies. I'll ask Dr. Ashkar at this point, what's the importance of pyloric gland metaplasia in these patients, JP?
Which he doesn't have.
Which he doesn't have, yeah. Well, why is it important to look for that?
Yeah, so pyloric gland metaplasia is another marker it's a marker of chronic inflammation. Could tip us a little more into thinking about Crohn's disease in the terminal ileal biopsies. But the general statement, it's a marker of chronic inflammation.
Dr. Shen?
So actually, this is our pathology, GI pathologist, is actively looking for the signs of granuloma and pyloric gland metaplasia. So our study showed it's pyloric gland metaplasia is not specific for people with the Crohn's disease of the pouch, but however, that indicate, like Dr. Ashkar said, the chronic inflammation. The presence of the pyloric gland metaplasia, either in the afferent limb or the pouch body, has associated a 3-fold increased risk for the pouch failure.
Thank you. So July 2010, the patient was admitted this time. He had, remember that he recently had his pouch afferent limb stricture dilated. He presented with abdominal pain and distension. CT scan was obtained, which showed distended small bowel, suggestive of obstruction, and a distended pouch. This resolved with conservative management. what would be the next step? Let's ask the panel. Let's start with Dr. Ramsey.
Ravi, I have a quick question. Was the patient put on was there a concern for a Crohn's disease when that stricture was dilated?
There were some concerns at this point. However, since the pathology did not confirm Crohn's disease, the fact that the previous perianal fistulae had healed spontaneously and there were no active signs suggestive of Crohn's at this moment, the patient was not placed on immunosuppression.
But there are several things. So making diagnosis of Crohn's of the pouch, as we all know, is a very difficult thing to do. But you've got several hints here, including the development of perianal fistulizing disease 5 years after pouch formation, the 15 centimeters of afferent lymph inflammation in the absence, as long as you tell us he's not on NSAIDs, that would be a very strongly correlated sign you get, for Crohn's disease. And then the inlet stricture, again, in the absence of NSAIDs, would be highly suspicious for Crohn's disease.
Actually, did you know how many ulcers were in the afferent limb? Because you can...
There were several ulcers in the afferent limb.
With 15 centimeters of disease. So.
But there was no CT enterography or biopsy confirmation of Crohn's disease, and the perineum at this point was normal grossly.
I mean, there was inflammation on the biopsy from the terminal.
Yes.
There wasn't pyloric gland metaplasia, but there was inflammation.
Exactly,
So.
and no granulomas. Any opinion from any of the gastroenterologists? Should this patient have been treated with medical management of Crohn's right at this point, after the dilatation?
Well, I guess I'm very nervous because of a number of the things you've presented. If you wanted additional information, you can use family history. So if there's a family history of Crohn's disease, that's very worrisome for the development of Crohn's in the pouch, and I think that's from a study that Dr. Shen did a number of years ago. You can use serologic markers. So these patients, or the patients who develop Crohn's, are often CBER1, capital C, capital B, IR1 positive. They're often ANCA, capital A, capital N, capital C, capital A positive, and ASCA positive. And so if the serologies are positive, if there's a family history in addition to what you already have, I would probably treat aggressively. I think the old, whatever the old saying used to be, that nothing brings out Crohn's like a pouch. So you're really going to have moderate to severe disease that you're approaching. I'd probably do top-down therapy with this patient.
Dr. Cohen, any comments?
There's something a little strange about this patient because the initial presentation was somewhat obstructive above the level of the pouch, and now the pouch is somewhat dilated. So everything's getting down there. And what I think needs to be done when you order a pouchogram is to make sure that you get a post-evacuation film to see what the evacuation potential is of a patient. They may have had inflammation which may affect the actual function of the pouch, and the pouch may not be emptying. I mean, more than likely there's a stricture down below, but I think it is important to get a post-evacuation film here.
Absolutely. This was one of the reasons that we had the pouchogram performed, because if the stricture was above the pouch, why is the pouch distended? Clinically, the patient did not have any evidence of a stricture, and the post-evacuation films, he was able to empty the pouch.
Was there an IgG4 stain?
We'll get to that eventually. So at this point, any thoughts as to the likely diagnosis? Again, the same differential. So how do we treat this now? Is it going to be medical therapy, endoscopy with repeat dilatation, or surgery?
So again, I have had patients that I have two that I follow, who've had, if the stricture is really severe and you can't do anything about it, it can be resected and then put the patient on anti-TNF. Now, if there are other approaches that can be taken with that stricture, perhaps you can use I think Bo has done some 4-quadrant approaches to the stricture. Dr. Shen has to try to relieve those. Plus, so I think you're talking about a combination. You're going to have to do some intervention and then, in addition, use medical therapy.
Well, which stricture are you talking about? The afferent limb as it enters the pouch?
The one, you nicely showed it there on the,
Yeah, no, I saw that, but
Beautiful.
we were talking about the everything coming down to the pouch and the pouch being somewhat dilated. So what was the anus like?
The anus was normal. There was no evidence of any Crohn's disease. There was no fibrosis. It was supple. The only abnormality detected on both the pouchoscopy and the pouchogram was the inlet stricture.
So this is one of the common sides of when the Crohn's comes back. For some reason, it finds that side-to-side anastomosis like an anastomotic site. So like pre-anastomotic area, like the pouch inlet is the area where it develops. So to me, this is a Crohn's disease. And I will scope this patient and to see what we're dealing with, how tight the things are now, how is it inflammation, is it stricture? Okay.
So these were the findings. Pouch inlet, there was still a 2 cm stricture. There was an acute angulation. There was ulceration. Apart from that, the pouch had a few small discrete ulcers, but these were almost aphthoid. The cuff and the ATZ were normal. Dr. Ashkar or Dr. Brzezinski, any thoughts as to how to manage this?
Were you able to pass through, Ravi? Were they able to pass through the
They
stricture?
were not.
So it's a tight stricture now?
Tight stricture.
Yeah, okay.
So something that went from a 15 centimeter long stricture to a 2 centimeter long stricture without angulation before, angulation now. So that without medical treatment, I could argue that this is not Crohn's disease related.
No, 15 centimeter of inflammation. It wasn't a 15 centimeter stricture.
But there's none now. Now it's 2 centimeters.
No, they can't. He has a stricture that's 2 centimeters in length, and you can't get through it. Or I guess it's estimated to be 2 centimeters in length, since you can't get through it.
Dr. Cohen, any thoughts how to proceed?
Well, something has to be done with that stricture. And what we've done on a couple of occasions, if it's actually very short, is to do a stricturoplasty over that stricture. And depending on how the original pouch was made and the way it was angled into the anastomosis, it can be relatively easy or extremely difficult.
I think that's the point, isn't it? This is the patient needs to be consented for even a potential permanent ileostomy when they're going to this procedure. That if the things do not add up, you get a pouch looking at you from inside if that stricture goes away. So they need to be mentally prepared and consented. Look, we'll try. We'll see what happens. We'll try to salvage the pouch because they're very keen on not losing them. And then I think that needs to be the case.
So I think there is consensus from the panel that we're going to proceed with surgery. Dr. McDermott, any difference?
yeah, well, but I agree with you that this patient should have a permanent ileostomy. But sometimes I get asked, what are my most difficult patients? And the patients who have a pouch due to what used to be ulcerative colitis, who then develop Crohn's, want to hang on to that pouch more than any other patient that I take. So again, I've only had, the 2 patients I've had have had their strictures resected, and then from an anatomical, they were able to do that, and then anti-TNFs. I don't know the issue of doing a stricturoplasty, but that's a fascinating idea. Have you had experience with that?
I think it's a pretty good, I completely agree with you, Professor McDermott. What I was trying to say was he needs to be consented for the possibility of the ileostomy if surgically the things are not feasible. That's what I meant. Yeah. Otherwise, the stricturoplasty is the right way to go on this one, on a patient who's motivated, who doesn't want to lose their pouch. Absolutely.
Yeah.
So the operative findings were the patient had dense adhesions, as we normally expect in these patients. There was a localized stricture at the top of the pouch. It was initially not very clearly evident, but quite often in these patients we tend to perform a pouchoscopy that helps us guide as to where the stricture is and how tight it is. This was at the site of the previous suture line. The rest of the pouch and proximal small bowel were normal. And these are the findings. As you can see, This is the top. This is what is known as the owl's eye, the top of the pouch, and you have a very tight stricture here with some associated inflammation. One more picture of the same, this time directly focusing on the inlet of the pouch. It's a little unfair to ask the surgeons on the panel as to what they would do, because it really depends. You need to get a feel for what's going on inside the abdomen too. But of course, yes, the options really are, if the top of the pouch is easily accessible, perform a stricturoplasty versus a resection with anastomosis. Of course, sometimes these strictures can be tricky because this may actually well be more towards the body of the pouch, which makes the operation all the more difficult. In this particular case, considering that the rest of the pouch was normal and the ATC was normal, the decision was to perform a stricturoplasty with a revision of the top of the J pouch and completion on-table pouchoscopy. And these were the findings. I don't know if it projects very well, but this is the suture line. So those the opening was opened up, and then a longitudinal incision made across the top of the pouch and the stricture, and it was closed transversely, just like a Heineke-Mikulicz stricturoplasty that's normally done for Crohn's disease.
Ravi, I mean, it looked pretty ulcerated. Does that concern you for doing a stricturoplasty with that degree of, I mean, it looks like it's all ulcer.
Not really. Quite often in these patients with Crohn's disease that are billed as a fibrotic stricture in the operating room, in reality we actually see inflammation. And once we're in the operating room, we're pretty much obligated, because it's usually failure of medical treatment, to proceed with the stricturoplasty. So this does not worry me.
I mean, just from a technical standpoint of doing the stricturoplasty with that.
It's actually amazing how these patients do well, and these stricturoplasties, actually the leak rate is pretty small.
So, Ravi, next question you will be you will ask will be the post-operative prophylaxis, right?
So now, having done this, I think what Bo's point was, how do we manage this? Is this Crohn's? Is it not? Do we manage this medically? Do we watch?
What did the pathology show?
There was no pathology on this occasion, although the previous biopsies did not confirm Crohn's. Because it was stricturoplasty, there were no biopsies, no segment for pathology.
I would go as a surgeon, be the big advocates for aggressive medical therapy, because if you want to salvage this thing, I think we need to treat this as Crohn's. JP is right, out of blue, 5 years, no problem. Suddenly you get these things on this thing. I think if the drugs are needed, this is the indication. I do believe, I think we need to go combination of the drug and supplement with the surgery. By the way, did you do a diversion at the time? Or you just did a straight
He had a diversion,
so, and then
that was
down.
subsequently closed.
Yeah.
So I have two questions. One is the fact that it's on the suture line and all those additions, could that be causing a focal stricture? And the other one, is there any concern for cancer when you have a stricture like this?
Well, this is definitely not a cancer. It doesn't look like one, and the previous biopsies did not confirm that. Adhesions generally don't present like this, although the external appearance can look like this. On pouchoscopy, you don't see a pinpoint narrowing as what we have here. Dr. Cohen?
But that's a good point. I mean, you could biopsy this from inside also. You don't have to do it at the time of operation. But in general terms, if you're operating and doing stricturoplasties on long-standing Crohn's disease patients and you see an ulcer like that at the base of the stricturoplasty site, you should biopsy it, because on the off chance that this might be a cancer.
JP, would you treat this medically?
Yeah, I think so. I mean, as the reasons I stated before, I think this guy has Crohn's disease. These are tough cases. You're never say never. It's uncommon that you're going to get something diagnostic on a biopsy, a granuloma or something, a hallmark of Crohn's disease. And although I agree with Dr. McDermott and I check serologies in these patients, my impression is that 80% of the time they come back not helpful. They come back as either read as ulcerative colitis, or I've had a couple where it says no IBD, so the serologies tend not to help me in cases like this. And I think you have to make a clinical diagnosis. In this guy, I'm fairly comfortable making a clinical diagnosis of Crohn's disease, and based on everything that he's been through, I would hit him hard with medical therapy post-op.
Dr. McDermott?
I agree that, you know, the combination of surgery plus medical therapy will hopefully keep this guy in good shape for a while.
This particular patient, we elected to repeat a pouchoscopy and evaluate whether or not he would develop new ulcers because it was so focal. One of the other questions is whether this was ischemia. I mean, the whole history, however, doesn't make sense that somebody would get symptoms like this several years after a pouch creation. Of course, you do suspect Crohn's. On the repeat exam, at that point, the patient did not have any ulcers after the ileostomy was closed, so we decided to not treat him with biologics or anything of that sort. 1 year later in follow-up, the patient had 15 bowel movements a day. Most of this were because of a sense of incomplete evacuation. No tests could really determine as to why this was. Even an anorectal and manometry did not show any obstructive defecation. He had some mild rectal urgency. There was no rectal bleeding or abdominal pain. He underwent a repeat pouchoscopy at this point, which showed ulcers in the afferent limb and the pouch body without any strictures. There were multiple discrete small and medium-sized ulcers at the distal 30 centimeters of the near-terminal ileum, ulcers in the pouch body along the folds. And these were the biopsies. Dr. Brzezinski, we're looking for the IgG4.
Mm-hmm. 5 out of 7 plasma cells.
So once again,
that
there's
many.
evidence of inflammation,
Yeah,
no
it's not-
granulomas.
I think that with this course, I would feel more comfortable calling it Crohn's disease. Previously, I'm not sure that I would. I agree that I wouldn't have started treatment immediately, but now I think that needs to be treated.
Dr. Shen, you want to give us a little bit of information about the importance of IgG4?
Yes, IgG4, we did a study on that. Basically, it's looking for is not that the IgG4 is a sign of the Crohn's disease. IgG4 is a sign of the autoimmunity affect the pouch. We don't know the rule as in terms of the pathogenesis of the disease. As the IgG4 is a chicken or an egg, but the presence of the IgG4 indicated the pouch was chronically inflamed. Number two, it's indicated some autoimmunity. Quite often, the people have the tissue infiltration of IgG4 cells. Typically, had the concurrent other autoimmune conditions. Actually, it went over the session with this morning. So, if they have a two organ was involved by IgG4 infiltration, such as a thyroid and then the gut, you may open in the future sort of like the new target of a therapy such as CD20 antibody, rituximab. Thank you.
So these slides are self-explanatory since we are running out of time. Briefly, pouch leak or an abscess can present as a sinus, and quite often these can mimic Crohn's disease. Based on retrospective data, we basically think that if anyone gets signs or suggestion of Crohn's disease within 1 year of creation of a pouch, you have to strongly suspect that this may not be Crohn's disease, but these are septic complications of the pouch. In particular, we have some data to suggest that when these patients present with a label of a Crohn's disease, you always have to go back to the starting block, make sure they do not have septic complications, because such patients can actually have a pouch salvage and have good results. Now let's go back to the post-test questions. But in a patient with ulcerative colitis, previous perianal fistulae always indicate Crohn's disease and are a contraindication to ileoanal pouch creation. Yes or no? I think that's much better than last time. Crohn's-related isolated long segment stricture of the afferent limb related to the ileoanal pouch is best managed with. And lastly, septic complications after an ileoanal pouch may mimic Crohn's disease. Yes or no? Thank you.
Thank you. Actually, this was closing our the conference, the dinner conference today. Thank you for sticking around. I hope I really thank the panel and our expert here, and we'll hope to see you next year at DDW. Thank you.